glad we're talking about this because I hate small talk. Like, I always end up, if I can't like get somewhere deeper than small talk with someone in like the first 1 or 2 meetings, like I generally decide that we probably won't be friends because I'll probably rub them the wrong way at some point. So yeah, small talk is not my gift. And so, but having said that, I've never like, kind of done introductions and like dived right into a period conversation. But
usually I feel like it's not a common thing.
Yeah, but thinking about it though, coming to meet you, I did have some thoughts. So I was thinking about why periods are stigmatized. And I've listened to some of your thoughts or some of your friends' thoughts on it. And I think for me, like, I think it's just the fact that we're bleeding. And I think, blood is like an injury response,
Yeah.
And so typically when someone's bleeding, they're like injured, or I think that where we go with it immediately is that they're weak, right?
Yeah. No, and I
even if it's acutely, like they're obviously injured right now, and so they're like out of commission, right?
Yeah.
And so I feel like that's how periods and stuff got tagged, or how women get tagged with some of these like kind of weak adjectives or something, because it's just like an injury response that we're like so used to seeing blood come out of people's knees and elbows and yeah, I think I remember what made me feel that way was, think about that was, I remember getting my period, and I'm still such a daddy's girl, and I remember making my mom sign this little contract that she wouldn't tell my dad that I got my period.
Really?
And like, why was that? It had to have been because it, like I couldn't be weak, or you know what I mean? Because bleeding is being weak, I guess, was what I thought my dad would think, or something like that. So yeah, I was thinking about that stigma and weakness, and trying to figure out how to tie that to mental health and addiction. And I think it's kind of the same thing, because just as we see blood as a symbol of weakness or like acute injury, I think that people see mental health as weakness, or mental health issues as issues reflecting some sort of weakness. And it's just not the case. But I think I loved what you said yesterday about empathy takes effort.
Yeah.
And it really does. Empathy really does take effort. And I think that it takes effort to understand periods and understand blood in a context other than weakness. And I think it also takes effort to understand addiction in the context of not only mental health, but as in the category of a disease, because we're so used to thinking of disease as bad cells multiplying and us being a victim of that. But addiction as a disease is just as devastating and sometimes equally unpredictable. So I think talking about that is can bring addiction ultimately out of stigmatization, in the same way that talking about periods we can disconnect it from weakness.
Yeah.
Having said all that, though, just incidentally, I don't get my period. I think one of your friends talked about the depot.
Oh, yeah.
A few episodes ago, but this is just like a fun factoid. But I started seeing a male gynecologist, which was like against my principles. But I called for an emergency appointment one time, and they were like, oh, well, we're booking 6 months out for your doctor, but this doctor is available at 8, 8:15, 8:30, 9, 9:30, 9:45. So obviously other people feel weird about male gynecologists too. But I love this guy. I love him. He's the coolest guy ever. First, I think because he's not a woman, he looks at everything the way that an orthopedic surgeon would look at a knee. You know, so things feel really quick, and something about female gynecologists sometimes make you feel like judged on some level because they can weirdly relate, and then like if it's not the same as what they're going through, then sometimes, I mean, maybe that's coming from me. But yeah, I love this guy, and he always, it's almost like he comes in and as part of his bedside manner, like launches into like a 20-minute, usually history lesson with me is what happens. And so this particular time I was asking him if I should come off birth control. And the reason is because, you know, you're kind of told that you shouldn't be on it for a long time. I don't know where that comes from. If it's like a scientific study, or I think it's just like people think that if you don't let something function the way it's supposed to function for some period of time, like our bodies forget how to do it. But this guy, my favorite doctor, had some interesting insight. So I asked, you know, should I come off birth control? And he said, for what reason? And I said, I don't know. I feel like, you know, he's like, do you want children? And I was like, no, not at all. And he was like, well, you know, I don't think you should come off of it then. And I was like, well, I've always heard what we just said, you know. And so he gave me this nugget. He said that in the 70s, when the pill was invented, it was originally engineered for 4 weeks of active ingredient, active hormone. So the first women who were on the birth control pill went on it because they wanted to control birth and wanted to get on a schedule so that they can predict and, you know, be more in control of that biological function, right? So they were given this solution. And since there were 4 active weeks, you know, come the 4th week, women were freaking out because they weren't getting their periods. Because it was so weird, right? It was the dawn of a new age. So they actually engineered they took out the 4th active week and engineered a week of sugar pills so that women would feel normal and bleed again. Because what was happening was people weren't getting their period, freaking out, stopped taking the pills, and then getting pregnant because they stopped taking the pills because they thought something was wrong with them because they weren't bleeding, right? Hilarious, right? So he basically, and I've accepted this to be fact, but I haven't done a lot of research, but this guy has. So I'm going to state it as fact. But he said that there's no biological necessity for women to have a period. That there's no biological reason that on a monthly basis we need to shed our lining, our uterine lining, which is like 95% of the quote blood that comes out of us. It's mostly other jazz and then like a teaspoon, like a little dollop of actual blood, right? So you know, he convinced me that, you know, he said that you know, do 2-year-olds get their period?
No.
Do generally 75-year-old women get their period? No. But he told me that if he gave them the birth control pill and gave them the hormone, that they would bleed.
That's so interesting.
Isn't that interesting?
I never knew.
Mind-blowing, right?
Yeah.
So
the premise of my whole show,
I know,
out the window.
Right? Well, I think that, like, you know, I think that you've done a great job of tackling why it shouldn't be stigmatized. But I think, like, I think that, you know, if it's stigmatized because it's a sign of weakness, I think we've debunked that because not only today in this conversation, just by saying there's really only a teaspoon of blood in a menstrual period, but also, like, kind of the fact that we biologically don't need a period, so whether we're having them or not, it's normal. And you know, so kind of having said that, mental health issues are super normal, and addiction is obviously something that affects 1 in 4 families, and it's why we're chatting today about the stigma of addiction and how it's related to stigmas like about periods.
Like, wow. I mean, I would think you'd work in politics. Like that whole circle, pulling that all together. And that's so true. And yeah, I feel like, because I've never even thought of it that way. Of it like, because it could be seen as a sign of weakness, and to me that was like, well now it's being thrown into the sexism of just stigmatizing periods where we can't like sexualize it. Yeah. So we don't know what to do with it. Yeah. So that like that's been my overarching theory, but that totally makes sense of it.
Yeah, I mean it's just I think to go in another direction. I think another huge aspect of both menstrual health, feminine health, male health, mental health is nutrition. Yeah. And I know that menstrual cycles are affected by nutrition. The reason for that is because our bodies are little factories, and just like that little dollop of wisdom that my male gynecologist gave me about there being no medical reason for us to have our periods, or equally no detriment to us not having a period. No detriment to us if we don't have a period. But yeah, I think I completely lost my train of thought.
I'm here for it.
I don't even know where I was going with that. But anyway, I think that mental health is stigmatized too for the same reason. And I think that people have a hard time looking at addiction as a mental health disease. But what I've learned from working with Eric over the past year is that whether addiction and mental health are on the X or Y axis, there's going to be a positive correlation. Because, whether you've had a substance use disorder, for example, your mother shot you up with heroin when you were a kid, and so you had a substance use disorder, your brain is still developing until your mid-20s. So a substance use disorder from that early an age would result in like actual brain damage, like to your frontal cortex during your development. Yeah. And then that mental health issue might result in you using substances to be comfortable. And equally, people who come into addiction from a mental health space, having a personality or mood disorder, those people also tend to take comfort in substances because you tend to self-medicate, because with mood disorders you feel different ways every day. Yeah. So some days you might be like, I'd like to just have some cocaine and that'll bring me up, or I'm feeling this way and I'm going to use this substance. So really, whether you're coming at addiction from a background in mental health, or you're coming from a history of substance use disorder and now you've like literally caused brain damage that you're dealing with, it's definitely a disease, definitely correlations that are clinical and medical. And I think that in the same reason that we don't clinically need to have a period, I think that we do need to be considering and understanding addiction to be a mental health disease. Yeah. That needs to be treated on a treatment plan like any other ailment that we have. Yeah. So I think that's hopefully what I want to tackle, and hopefully this will help tell the people of the world. Please consider addiction to be a mental health disorder, because it absolutely is. And I think that's where a lot of the stigma comes from.
It's just the ignorance of not.
Yeah, and I mean it's
taking that lead.
And I before I met Eric, I was not empathetic, and I hadn't put the effort into the empathy around addiction. And when you see someone make a recovery from addiction, it's clear the juxtaposition of their everything from the way they're making decisions to the way they're seeing life is completely different, that it can be explained in no other way than having gone to treatment for mental health disease. So it's really nice to see people make a recovery. And sometimes it takes people 9 and 10 attempts at going to treatment to get into long-term recovery. So relapse is certainly a part of recovery that I think also wears on loved ones' patience in understanding the disease.
Yeah.
Yeah.
But that's like anything else where you know, if you don't succeed, you know, try again, kind of. I mean, it's a very basic and generic way to put it, but it's like we do that with how we treat cancer, or
Yeah.
we do that with everything else.
Yeah.
But there's so many people who excel in recovery that, like, say, like, my mom has, like, introduced me to or whatever, and it's like, yeah, I've been clean and sober for like 35 years, whatever. Like,
Yeah.
that's a huge accomplishment, and
Yeah.
they fly under the radar.
Yeah. Well, because I think it's almost like because of the stigma, and whether that was something that came from within people who had the disease and were feeling shameful, or practitioners who treat people with the disease and treat them in a way that makes them feel like shameful about having it.
Mm-hmm.
I don't know what it is, but it tends to be a quiet community of people in recovery. But now that I'm in this space, now that I'm in the field of behavioral health, I see that a lot of people in recovery tend to work in the field.
Yeah.
And to your point, like, you talk to someone who's exactly like you in every single latitude and longitude, except that they spent 5 years dealing with substance abuse while they were going to school, or while they were doing their things that you were doing too.
Yeah.
So I think that we just have an inaccurate picture in our head, just like, you know, blood coming out of anywhere doesn't necessarily mean weakness. I think that, you know, mental health disorders doesn't mean weakness. I think it just means that more energy needs to be put towards that. Just like if we were to go to the gym for a week and expect those results to last us a whole lifetime, mental health is something that needs to be worked at, and people don't put a lot of energy into it.
Yeah.
At all. So.
Yeah. Fix all these world problems today. Yeah, just yeah, because yeah, and I guess that's, I mean, our own culture too, just in anything, just expects immediate. So that's, I guess, the other aspect to fight against too, is if you're living in a culture where you can get whatever you want, I mean,
yeah,
virtually, like, as fast or as soon as you want it,
yeah, then
long-term recovery is probably like unrealistic for like a lot of people, or at least to visualize.
Yeah, I think that that's a good point, and I think that, you know, I think one thing that helped me understand cancer in a really simple way was I was in an interventional radiology suite in Hershey Medical Center for training for a previous job, and the doctor, the radiologist, was talking about how we were talking about protective gear. So radiologists, like when you go to the dentist and they put a lead cape on you before they take your x-rays, you know, radiologists have to wear, and people in the room when they're doing interventional radiology procedures have to wear lead to protect against the x-rays. And so he was saying that there wasn't really any gear worn by these physicians in like the 50s, 60s, and 70s. I think the earliest interventional procedures might have been done in the 70s. And so there were all these doctors dying of radiation poisoning because they were just getting radiated on for hours and hours during these procedures. And the patient was draped with lead, but they weren't. So he basically said that wherever there's chronic inflammation, that's where you tend to develop cancer cells. And it makes sense, right? Because if something is constantly expanding and contracting, there's a higher chance that there's going to be bad DNA cells that develop and start replicating in that area, right? That makes sense. So if you extrapolate that onto a brain, and whether you look at it that from a perspective of trauma, like wherever there's chronic trauma, you know, a kid that grows up with his or her mother selling drugs for money, so they might be stepping over someone using crack in their living room on their way out to the bus. I mean, that's chronic inflammation.
Yeah.
You know, right? And then, or people who live in an abusive scenario, or people who have parents with addiction, and growing up, you know, they see that and they have to deal with that, and they might have to help their sick mother or sick father up off the bathroom floor, or, you know, remind them to do things that parents should remember to do. And when that ecosystem of the family gets messed up, there's chronic inflammation there.
Yeah.
Right? So it makes sense if you look at it, in the same schematic as other types of diseases. If you have chronic inflammation of the liver, which happens by drinking too much alcohol, and you get cirrhosis of the liver eventually, that's just the liver is tuckered out from processing all the toxins, and it loses its ability to do so. So when someone gets treated for a cancer like that, people are very empathetic, because it's like, oh my gosh, this poor person who had no idea that they were getting cancer. But not all of, but some of the diseases that we treat on a really regular basis without stigma are very much the same level of like decision making that got people on that hospital gurney versus on, needing treatment for mental health or substance abuse. It was just different inflammation.
Yeah.
Does that make sense?
No, that completely makes sense.
Yeah.
And I think that's a really good analogy.
Yeah.
Yeah. Because I think it's hard for people to put it in that perspective, again, because, I mean, what this is all about the stigma, where it's like, oh, I'm seeing a criminal. I'm not seeing, like, a sick person or something.
Right.
So, yeah, just being able to say, like, these people are coming from, like, broken homes, or these people are coming from poverty, or, like, things outside of their control.
Or, like, a 12-year-old who gets shot up with heroin. Like, do they know anything else? Do you even remember being 12?
Yeah,
like, give me one solid memory from, like, you being 12.
Yeah, there's no,
No, I cannot place myself as a 12-year-old. I know that I was, like, doing things that probably affected my, like, where I am now. But we don't remember. But someone's mom was like, hey, baby boy, like, I love you so much, and heroin has been the best thing that's happened to me in my life. So let me save you the suspense of life and give you some of the best thing you'll ever have. Mm. So I think we stigmatize that mother, right? We stigmatize her for injecting her kid with heroin, right? But she might truly, if she's that same girl who was stepping over, someone using crack in her living room on the way out to the bus, like, that's literally all she knows.
Yeah.
Because that was even before 12, right? So we stigmatize that mom because we can't understand how someone could bring someone else into this world and then shoot him up with heroin. But her mind is completely consumed, by being chemically addicted to a substance. So you can't extrapolate our logic onto what she's thinking. I've met absolutely incredible people in recovery, and one woman said, my son is everything to me, and what made me want to go to treatment is I was laying in bed one night when he was 5, and he was calling for me, and I couldn't get up, couldn't move my body to get up and go to my son, and that's when I realized I need to go to treatment. But he was already 5. And now he's great, and she's great, and she's in long-term recovery, and he's like a football player or something. But, some people, I mean, I don't know if we can all relate to that exact scenario, but I'm sure we can think of a time where we were not in good shape and we were trying to get up, but we couldn't.
Yeah. Or just, being wanting to confront a challenge, but can't.
Yeah.
Just making it that simple.
Yeah, and so if someone like that realizes they need to go to treatment, the first hurdle then is finding a treatment that is appropriate for them. So, and that's, I think, where the rubber meets the road on how we can help more people who are affected by this disease, is making getting into treatment easier. You can't change the choices that are made up until that point. So things that are sold or jobs that are lost before someone wants to go to treatment. So a lot of times their current situation limits their options. So if you are uninsured and have no transportation and you're living in an area that the closest treatment facility is like 2 hours away from where you're living, you're in a super bad spot.
Yeah.
Right? And when we're desperate and in crisis, we expect our community to rally around us and pick us up and take us where we need to go. But, it's hard for people to want to do that when the things that you've done to get yourself in this situation are completely not able to be related to by people trying to help, So I think, the first step is finding the right treatment program. And I think lay people like me a year ago, thought that you could just go to emergency room and get treated for addiction. But just like I can't go into an emergency room to get treated for a broken arm unless I have a broken arm. I have to meet medical criteria to be treated for a broken arm. So if you come into the emergency room and you've just put down a liter of vodka and you just think that that's the last liter of vodka you're going to be able to afford, so you want to hurry up and scoot over to the emergency room before withdrawal kicks in, it's likely that you'll get discharged from the emergency room because you're probably 24 to 48 hours away from going into withdrawal. And withdrawal might allow you to meet medical criteria to admit through the emergency room. But if you're at a 3.5 blood alcohol level, you're not meeting criteria to admit in the emergency room and you're discharged, maybe with a 2-day Librium taper or Ativan taper. And you've been drunk every day since 1997. So 2-day anxiety help isn't going to change your home situation, isn't going to change the people in your environment, the job you don't like. So that's why this disease needs to be treated like other diseases, and a clear-cut treatment plan needs to be followed, because just as difficult as it might be to go to outpatient like physical therapy after you get knee surgery, it's just as difficult to follow a treatment plan, if not more difficult, when you're drunk, homeless, and uninsured. So we have to have people in places like emergency rooms that help triage people who don't meet medical criteria in the emergency room, triage them to treatment for mental health and substance abuse, versus them getting discharged on a 2-day Librium taper and then, getting caught and charged on possession, and their mental health now becoming a criminal issue because it's not medical. And it's not, so we discharge them, and it's mental health, but we got to work on that stigma.
Yeah. And even like say if that person ends up in the criminal route, right, is that there are so many jails where not even AA is available anymore for people in jail. So
yeah, well, I mean, if you have addiction and you wind up in a jail, I mean, that's a very, very painful process to go through withdrawal without any medical stabilization. But and from what I've heard, drugs can still be gotten in jail. So it's just another reason why, fortunately here where we are on the eastern shore of Maryland, and Maryland in general has had rampant drug issues for 30 years. So fortunately, these areas are more progressive with treatment, and the local and state governments in Maryland are more willing to help push people into treatment for mental health and addiction than they are to get them jammed up in the criminal justice system. But in other parts of the country, like for example in Virginia hasn't had as rampant a drug issue because, maybe that's socioeconomic, whatever, I'm not an expert, but they're not as progressive. So if someone gets caught with, essentially 2 servings of a drug, usually that's immediately like intention to sell or intention to distribute. So, yeah, fortunately living in this area, I think there's a lot of positive movement towards getting people into treatment. And I think, refreshingly enough, there's a lot of treatment available. Still not enough to accommodate all the people who need the services, but there are treatment options available. In going through this process of kind of helping Eric, who was a person with Medicare, who has Medicare because he's on disability. But he was homeless when I met him and addicted to heroin when he returned my stolen purse to me. So, helping this complete stranger who has a completely different background from me navigate, getting into treatment. And I think he's probably like a very common case, but so am I. I mean, if I had addiction, I'd be very average too, because addiction is completely non-discriminatory in who it affects. you know?
Yeah.
So, but going through that process with Eric really helped me in a positive way see that there's a lot of treatment resources available. But because there's no like standardized governing body over treatment, there's a lot of unscrupulous players, and there are some who you know, make a profit from having people relapse, or basically not discharging with an airtight treatment plan so that someone could follow it. For example, when Eric was discharged from treatment, no one checked, I guess, that his Humana, well, his Medicare Part D coverage, which is the prescription coverage, is usually picked up by an employer if you're employed. So he was not employed, so his Humana, which brokered that benefit, had not been paid by an employer because he was homeless and unemployed. So he was discharged from rehab on prescriptions, which I think confuses people sometimes. But he was discharged from treatment on prescriptions, and then he wasn't able to fill the prescriptions because he didn't have Part D coverage. So I had started a GoFundMe page for him, fortunately, and we spent some of that initial money on buying his prescriptions. But for everyone out there who doesn't know why people go into treatment for drugs and leave on drugs, I can clear it up a little bit. People who are, you know, I don't want to like liken it to chemo, but basically, if you go into treatment on, you know, using drugs recreationally, you don't know what your dosages are, right? So when you check into rehab, a clinician will evaluate you just like any other medical treatment and determine, you know, what level of care is needed. Usually if you're chemically addicted to a substance to where you experience withdrawal when you stop using the substance, your symptoms will then need to be medically managed. So depending on how much you're using, alcohol, drugs, whatever, that generally that substance amount will need to be matched by a pharmaceutical that is obviously dosed so that they can match your, you know, they can basically medically manage your withdrawal symptoms. So sometimes someone's taper during that process is longer than their stay in treatment will last. So they're discharged with medications to the next level of care, hoping that someone beyond treatment will help them manage their medications. But that's definitely an ideal that's not usually met. So that's where a support system for someone with addiction really comes into play. And sadly, people don't always have a support system anymore when they discharge from treatment because they've probably aggravated their family to the point of, you know, not having them anymore. But it can all be recovered. Is the good news.
Yeah, and despite everything that anybody trying to get into recovery has to fight, even just like how we treat the pharmaceutical industry and how we like commercialize it in this country, which is obscene. That's a whole different side rant. but just those, it was like those rehab commercials. What's this? I forgot the guy's name where he's like, I was an addict and now I'm not. Like like that kind of stuff.
Yeah,
where it's just like on top of the business of recovery, which is dumb. Yeah. And then the relationships and everything. It's this. I'm putting it into perspective for people. Is just this person is fighting against every possible thing that could.
Absolutely.
There's no advantages anywhere except for themselves. So it's just.
It's kind of like a scavenger hunt when you're drunk. Yeah. Like a drunk scavenger hunt. Yeah. You know, and like. Not to make a joke out of it, but like I think we can all relate to a scavenger hunt and to being drunk. And it's obviously exponentially harder to do the scavenger hunt. Maybe temporarily more fun, but like definitely harder to complete the activity when you're drunk, right? And so people who are in a position to refer people with addiction to the treatment that they need. Sometimes they're in the hospital, sometimes they're a first responder on the scene of an overdose. Whoever has that opportunity, it's important for them to not, you know, go into that situation with a stigma, because they might be the one who influences whether that person goes to treatment or not. And if they're looked at, like if they get this look, I mean, people know body language is enough to, make someone feel a certain way. So, I mean, I think that's important is just, but it's so hard because those poor first responders see really tough cases all the time. And I can imagine it's so hard to empathize. But if we could just understand that when someone's in the throes of addiction, they're not thinking like even they would in a rational situation, Yeah. They're in complete fight or flight mode. So yeah, I think just to tie a nice little bow on it, I think it's just as important to follow a treatment plan to recover from addiction as it is from everything else. If you were to get total reconstructive surgery of your shoulder, your physician would give you a treatment plan and say like, hey, if you want to be acting and on stage again in 6 months, like these are the things that you need to do. You need to go to this physical therapist and you need to follow this treatment plan. And, if you ask a physician like that, like what's your success rate? I mean, they have 100% success rate if people follow their treatment plan, right? Yeah. But I don't think those doctors' waiting rooms are filled with people who are following the treatment plan. I think they're filled with people who are not compliant and don't follow the treatment plan, and they want to come back and say, like, you didn't fix me. And it's like, well, what are you doing? Like, are you following your treatment plan? And so, unfortunately, with this, it requires a lot of energy. And not only that, but resources. I think I've come to understand transportation, housing, and employment to be like the Bermuda Triangle of early recovery. And if you don't have like 2 of those 3 things, it makes following a treatment plan impossible. So you're dealing with someone who is probably, in order to get in a position to accept treatment, has probably lost all those things. And then you're asking them to rebuild those things after 7 to 28 days away from a substance that they were using because it made the stressors in their life more comfortable to deal with. So it's asking a lot of someone to go back into the exact same environment they were just in and make different choices. So the treatment plan is essential, and I think people and families starting treatment need to understand that the tough times are not necessarily behind them. And that things have been really tough, and they've gotten to the front door of a treatment facility, and things will continue to be tough because they need to do their outpatient work. And addiction is one of those diseases that will make you think a year, 2, 3, 5 years into recovery that you now could have a drink, or you now could like have a little of this or a little bit of that because you're in a different place, and it's not going to affect you the same way. But the reality is that addiction is a disease that's like, while you're having those thoughts, it's because the disease has been in the back of your mind doing push-ups for the past 5 years. And that's when people, relapse because they think they're in a different spot. Yeah. So recovery never ends. It's forever. Just like a period. Yeah. Well, at least until a certain time.
Like, to me, it feels like forever. Like, I'm in a place where it looks like this is, but my, it's like my friend who the one that was on Depo, where she was talking about having a baby. Yeah. Because in Maryland, that's a whole thing where you can't have a baby at home because it's considered child endangerment, but she wanted a natural birth.
Interesting. I didn't know that.
So that whole bit was she's just like, we're taught that we can't handle our own bodies, but we can perfectly do that. Yeah, for sure. She was talking about like contractions, and then like, oh, it's just like really bad period cramps. And I'm like, thank God, because I was like, all this time I've been wasting. Yeah.
Well, that's another thing, just talking about that, like accountability for your body. I mean, people, I think, put a lot of weight on healthcare providers to solve all their problems, but they're not willing to put in any of the work to like fix my high blood pressure, fix my pre-diabetes, fix my all of my joint and muscle pain, like my fibromyalgia, fix all of this, but I'm not going to change any of my diet, any of my physical activity, my lifestyle at all. I'm not going to make any changes. I just need you to fix me pharmaceutically. And that's a tall order.
Yeah.
You know? So just like with addiction, just like any other illness, it takes a heck of a lot to get into treatment, and then it takes a heck of a lot to maintain sobriety after treatment.
Yeah.
But the people who are in recovery who I've met are the most like inspirational and passionate and hopeful and loving people and supportive I've ever met. I mean, we see movies where AA groups and support groups are represented, and it's like people sitting in a circle kind of like with unrelatable issues, or sometimes relatable, but I feel like when they're pictured in movies, everyone's really sad and down, and I think probably some support groups are like that. But I mean, if you go to an AA meeting, I don't know, have you ever been to an AA meeting?
Yeah. I've met like a lot of the...
They're wonderful.
Yeah, they're great.
They're wonderful.
Yeah.
I mean, and so I think that fellowship aspect of going to meetings and being around people who are also struggling will also help destigmatize things. So I think it's important, if I'm using this as a little bit of a PSA for families and, you know, people in recovery, is I think more specifically for families, while your loved one is in treatment, it's important that the family goes to treatment too. And people think that there aren't resources available, and there are fewer for sure for families. But, you know, you just need to continue to communicate about what you're going through, because when people are in a family, whether that's like what we think of traditionally, or whether that's the modern families that many of us are in now, where it's just kind of like you have some friends, you have some family, you have some pets, like whatever your little ecosystem looks like, whenever someone who you're connected to goes down, like whether that's from illness or whatever, whenever they leave, other people in the family, you know, cover for them. They cover their roles, they take the trash out, like whatever that person was doing, they fill in, right? Yeah. So when that person comes back in a week from the flu or whatever, like everything goes back to normal. But when that person's absent, you know, for a longer period of time, maybe just emotionally absent, maybe they're physically present, but they're, you know, stealing from the family to feed, you know, their addiction or whatever else, the family really like gets fractured because they're covering for each other's roles, and people get confused on what their roles are. So then when someone comes home from treatment, when someone comes home from treatment, then they're, you know, they come in with that, you know, I think we're used to seeing those images of people coming home from recovery, like on the front cover of brochures, where they're like, arms are out over their head and they're looking over a meadow and the sun's shining in their face, and that's like the classic, like, I'm free.
Or like a beach.
Yeah, like arms up, like I'm like healed. But, you know, they walk into their house after that and the family is still like fractured from when they left, you know. So I think, again, if I'm using it as a PSA, I just want to tell all the families out there that like the battle doesn't end when the person agrees to go to treatment, because then the family has to repair, so that when the loved one comes home, there's not resentment, there's not frustration, there's not lingering things that ultimately will create, you know, the situation to come back, cause the situation to come back. But yeah, those are my thoughts on the matter.
I think that's a really good way to, like, I was gonna say, do you have any final thoughts? But you did a whole PSA.
Yeah.
Wow, it's really well put. Yeah, so I guess for the person that's listening, maybe in the Maryland, Baltimore area, do you have any resources that you can maybe offer them? It's like, hey, like, go
yeah.
here, or like...
So I would say I'm going to give a quick educational closing statement.
Yes.
So for those who, I think the hardest thing with addiction is when people are trying to help people with addiction get into treatment, they're often in crisis, because the person usually hits rock bottom and then decides they want to go to treatment. And so rock bottom's like a scary place to be. And the person helping is usually, you know, in crisis, and so is the person needing help. So, you know, if someone is experiencing the symptoms of withdrawal, it's great to take them to the emergency room, because, you know, medical symptoms exist to be treated there. If someone, is wanting to go to treatment but isn't currently experiencing the symptoms of withdrawal, a good first step would be to call the back of an insurance card and see what providers are covered under insurance. If you call a provider directly, they'll be able to tell you if they can work with your insurance. So I would say, locally in Maryland, for anyone who's listening, and, on a national scale, the good news is that help does exist. The bad news is the infrastructure for it is kind of like not as developed as we're used to seeing with other treatment plans, because I think, again, the stigma and the emphasis that was taken away from the mental health budget on a national scale like 20 years ago. So we're a little bit behind, but the good news is, treatment options do exist. Treatment providers, there are some unscrupulous players, like I said, but typically people in these roles want people to see people get better. So I would say, again, if someone's meeting, if someone is going through withdrawal, I think the emergency room is a good place to treat acute medical needs. Otherwise, calling a treatment provider directly, you can expect a 10-minute assessment of the person needing treatment. So the person needs to get on the phone, usually with the treatment provider, and do a 10-15-minute assessment so that the provider can understand the current medical symptoms and whatever else is going on clinically and what substances are being used. And then once, someone's in treatment, family or loved ones or the person in treatment needs to start thinking about next steps. So one of the things that I really enjoyed recently was there was a 60 Minutes about a sheriff who was trying to work on programs in Cook County Jail, which apparently has one of the highest recidivism rates. So he was trying to address repeat offenders, which is also a common characteristic of this disease as well. People tend to come into hospitals over and over again, the same people. He implemented a chess program, like chess. And the thought process there was that in order to be good at chess, you have to be able to not only anticipate your counterpart's moves, but prepare for how you're going to respond. So you have to think about your moves 3-4 moves out. And so his feedback was, a lot of people in the program were like, wow, I've never thought like this before. I've never thought 3-4 moves in advance. So to kind of finish up with my treatment plan rant, I think that once you're able to get into treatment, you need to start mapping out a full year of treatment. So okay, I'm going to discharge here in 30 days. Where am I going to live? Can I go back to my house, or are there people, which happens all the time, a family uses together, spouses use together, boyfriends and girlfriends use together. So is it responsible for me to go back to my environment, or do I need to secure sober living while I go to outpatient therapy after a discharge from inpatient treatment? Then how am I going to get to outpatient? Am I going to be able to get there 3 times a week for 3 hours in the evenings? Is that feasible? If not, what do I need to do to extend my residential treatment or whatever until I'm able to secure housing and transportation? So I think that the best advice is, treatment, can be found, and then really taking ownership, just like we would of our periods or anything else, take ownership of our own health, because ultimately no provider is going to take as much interest in your health as you are. Yeah. So we can't just put all of that into the hands of our clinicians or our providers. We need to take ownership of, this is my body, this is my situation. I'm going to arm myself with information, and I'm going to be prepared to fight this disease for an entire year. With a combination of inpatient, outpatient, and going to meetings or individual therapy, whatever works. But I would just start to look at this as not a 7-day go to detox and you're going to be clean, but a full year process that starts with a really solid treatment plan in the first year.
All right. Yeah. So that's I think the most structured treatment plan I think I've ever heard, because the only thing I guess I would see is like the commercials that are like, come to our magical facility
Yeah.
where you'll be perfectly fine.
Yeah.
And then go back to your prairie happy life and
Yeah.
never do drugs again.
Right. Yeah. So it definitely takes a
Very
lot of
practical.
effort. It takes a lot of effort, just like other illnesses do.
Mm-hmm.
Takes a lot of effort, and I just think that we need to appreciate it as more of a sign of strength when someone decides to go to treatment, than a sign of weakness. And obviously, women getting their periods is the strongest thing that ever happened to the world. So,
Amen.
yeah.
I think, this is last little quick thought, is that the pain of giving birth statistically is the closest thing being burned alive.
Oh, lovely.
So every woman that's ever had a child ever, unless they meet somebody that's been burned alive, I respect that pain level.
Yeah.
So.
Yeah, and I think that, not to be cheesy, but, listening to that episode with your friend, I mean, it was clear that, like, she was super passionate about being a mom. So I think the takeaway from that is, like, we can do whatever we want to do.
Yeah.
And if getting sober is what you want to do, it's definitely achievable. But I think the right expectation needs to be set. So whether you go into that situation feeling like it's going to be like being set on fire, or whether it's just, little more than period cramps, I think that the expectation needs to be that I'm going to have to work at this every day for the rest of my life. And I want that because I being sober is a way better place to be than where I am right now.
Yeah.
So, yeah.
Well, sweet. Well, thank you for being on the show.
Yeah, thank you for having me. This is awesome. First time I've ever talked about my period publicly, and I don't even get one now. I don't think I explained why, but it's because he just writes me a script now for every 3 weeks.
Oh,
so I never take the sugar pill week. Boom.
I'm a bitch. I get it like right.
Yeah, well the great thing about it is that since it's all hormonal, then I don't have that roller coaster either. So for me, it's just been practical not to get a period now that I know there's no clinical necessity, but I'm sure that you're going to get blown up with comments about that. So feel free. I'll forward them to my gynecologist.
It's good because I encourage any woman to be whatever kind of woman she wants to be,
Yeah.
She's
I'm like a non-menstruating woman, and I'm okay with it.
Good for,
I'll keep you posted. But.
Yeah. Yeah, so I'm glad. Good for you.
Thank you. Thank you.
So
I feel empowered.
Yeah.
Taking control of my health, right?
That's right.
Yeah.
Good on you.
Thank you.
Cool.
Thanks, Mary.
I don't know if we can find you anywhere. This is the part where I'm like, hey.
Sure. Yeah, I appreciate it. So, I had met a guy named Eric McCoy, AERIC. When he returned my stolen purse to me a year ago. And I offered him a job, but he said that he wouldn't be able to keep it because he was addicted to heroin, and he found my purse when he was shooting up in an alley in West Baltimore. So I offered to help him go to treatment, and a year later, I ended up changing jobs because I'm super passionate about this, and I am still really close with Eric. But if you're interested in our story, you could go to GoFundMe.com /Eric's Fund, AERICS, Eric's Fund. And then I spoke a little bit about working with Eric over the past year. I've noticed that kind of, like I said, that Bermuda Triangle of early recovery, transportation, housing, and employment. I've been trying to tackle those issues by kind of strategic solutions in the continuum. I think that transportation is the first that's encountered because people who want to go to treatment sometimes can't get there, and that's where people fall through. I mean, it's the most basic thing, but they can find treatment and then can't do the $37 bus ticket or like the taxi ride over to treatment. So it never happens. So I've been trying to tackle concerns in transportation, housing, and employment by way of creating, right now it's a Facebook page, but it'll be a website called advocate.org. But right now it's a Facebook page called Advocate, and kind of playing off of Eric's name, it's AA Advocate, so AADVOCATE. And so on Facebook, the page is Advocate Team, and it's also Instagram at Advocate Team. But we are looking for providers and other community members who have creative and sustainable solutions in transportation, housing, and employment for people in recovery. I'm looking to bring all those people and causes together under one umbrella, so it's easy to find not the treatment, but the supplemental pieces, literally the logistical pieces that go along with trying to follow a treatment plan in early recovery. So I don't want to be a treatment provider, but I want to be a supplementary piece that allows people to follow a treatment plan. So you can learn more about that on AADVOCATE advocate team on Facebook.
Awesome. And we will put the GoFundMe and the Facebook in the description, so
awesome.
You can find that there. And then Tampon Talk is on Instagram, if you're not following it already. So we will post that there as well. So if there's a bleeder or not bleeder listening and they're like, hey, I know somebody, then hopefully we make these worlds meet up together. So that would be really great.
You guys, you got to listen to Mary's other interviews. They're hilarious and amazing. Today I learned in a very graphic and visual way what a placenta looks like. So be sure to tune in this month and every month for some enlightening conversation with Mary.
Have some placenta.
Yes, absolutely. I am totally Googling what a placenta looks like now because my mind is blown.
Yeah.
And you can make it in pill form? Are you kidding me? People are out there doing science experiments on placenta, and I'm here talking about, whatever I'm talking about.
No, Cece is, she is an angel. She actually lives here. She lives here, secret's out, we're recording in Easton. But, she actually lives here. She's a wedding photographer. So
awesome.
You ever bump into her while you're here?
Absolutely.
You can ask her about her placenta.
Yeah.
Just casually.
Yes, I will ask her about her placenta. She seemed pretty open about it. So, yeah.
Well, great. Yeah, thank you for being on the show.
Thank you.
Yeah, and then you, Tampon Talk listener, let me just plug this real quick. If you have any extra questions, sure you can send it to our email, tampontalkwithmary@gmail.com, and I would forward them to you if you're open to that.
Absolutely.
Any more questions about addiction or any more questions about Kaitlyn, whatever your heart desires. You can follow us on Facebook, Tampon Talk with Mary. We'll also be Facebook buddies on there so that we can post your advocate page there. And then Instagram and Twitter, we're Tampon Talk W Mary. So hit that follow button, like our pictures. I need the attention, please. Thank you.
Do it. Give her attention.
And great, yeah. And you, listener, if you are thinking about treatment, you've got the strength and you can do it, and you totally
follow your treatment plan, people.
Follow your treatment plan.
Absolutely. And if you need any help getting into treatment, Mary told you where to find us, so we'll be more than happy to help.
Yeah, and you've got the support system, so all the best for that. If you're just a normal bleeder or you're not, keep on bleeding or not, I don't care. Live your best life.
Or talk to your gynecologist about maybe just taking the 3 active weeks on the pill and skipping over the bleeding.
To her male
and
gynecologist.
Then absolutely. Get a male gynecologist if you haven't looked into it. Just consider it. They usually have available appointments.
Oh, yes. Burning stigmas left
absolutely,
and right.
Just karate chopping those stigmas.
Well, great. Thanks for listening. And we'll see you next time on Tampon Talk with Mary. Bye.